Um, Ladies and gentlemen, I think it doesn't need any introduction that this is going to be an industry session, and the industry session would be on Hoya. I'm here to speak on the Vivinex toric and my experience with it for the last year or so, since the time it was launched. Before we go into the IOL proper and discuss about the nitty-gritties and the different angulations that form and assemble to bring out a complete product to us in the industry, I would just like to outline the way I go when I choose a particular manufacturer or a particular IOL to be incorporated into my practice. Why this is important is because when we get visits from the manufacturing houses that work with us in the industry, sometimes we face quite unprecedented pushes from them so as to incorporate the AT-IOLs, because all the manufacturing hubs, manufacturing companies right now are coming in with the monofocals and the AT-IOLs together, and the focus product is always on the AT-IOLs and not the monofocals. In my case, it's always the reverse. When I incorporate a particular product or a particular manufacturing house into my practice, I always go this way. There are 3 steps. I first try and test their monofocals. If they satisfy me, I go to the next segment, which is the torics. And then if I'm satisfied with both of these, then I go to the 3rd segment, which are the trifocals and EDOFs. Now, Hoya, along with a few other very selected houses, have done a wonderful job in coming out with the monofocals first, ensuring that it has an established platform with the practitioners, and then went into the torics. And once they knew that the monofocals and the torics are both satisfying the customers or the practitioners, then they would venture into the trifocals. They're yet to be launched officially in India and started being used clinically, but they're coming with it very soon because they knew that these 2 former segments have been able to satisfy. In the monofocal segment, what we look at is the material, the implantation science that goes behind it, and most important of all, the rotational, the behavior of the IOL inside the bag after its implant. If we observe the IOL's behavior for the next 6 months, how is it behaving? Is there any refraction drift? Is there any astigmatic drift from the time when we saw the patient for the first time after surgery after 2 weeks? So over a period of time, in 6 months or so, it should be stable, and there should not be any refractive surprises or drifts. That is very important when we go to the next segment of torics and then on to the trifocals and the EDOFs. So that's exactly what happened in my case. I tried the iCert and the Vivinex multi-cert first. I was very happy with the way it behaved post-operatively inside the bag, inside the eye. Then I went on to the torics. I was very happy with the torics. Now I'm ready and eagerly waiting for the trifocals to be available in my inventory so that I can go to the next segment. So that's how it's been in my case. So that's how I desire should be in everybody's case. Now let's come back to the subject proper. So this is the IOL that we are going to discuss about briefly. However, this particular design of IOL assembly is the iCert platform, where it was just the rotation that was pushing the IOL in. They're also coming in with the multi-cert assembly in the toric platform, where you can push or rotate or screw, whatever is your choice. It is a preloaded like all other IOLs in their portfolio. Nothing about the material. We all know that anybody who has got an experience of using, I'm sure Dr. Sonu would also agree with me, and he'll be coming up with his next talk, what the material quality is like. It is outstanding optical quality, very minimal water content, and it's very clear. I think Vivinex is one of those IOLs. In fact, there's just one other IOL that's there in the market. You know, when you ask the patient to sit in front of the optical biometer and you do not tell the optical biometer that it's a pseudophakic eye, you do not tell the optical biometer that it's a pseudophakic eye, the optical biometer automatically changes its mode into pseudophakic mode, particularly the IOLMaster 700. It always recognizes there is an IOL inside, so it changes the mode to the pseudophakic mode. Vivinex is one IOL wherein if you ask the patient to sit in front of the IOLMaster 700 and and take the measurement, the machine does not recognize that there's an IOL in place. It is so clear that it behaves like the natural crystalline lens. So it stays on the phakic mode. It does not transform into the pseudophakic mode automatically. You have to choose it manually. Otherwise, the machine does not recognize that there is an IOL in place. So what I mean to say by this is the material quality is excellent. It is very, very clear. And when you implant it, the unfolding speed is just optimal. It is neither too long nor too short. The other thing that goes into the implantation science of this is when you fold and it automatically folds both the haptics onto the optic surface, but the moment it goes into the eye, it never sticks to the optic surface. Perhaps one of the reasons why it does not happen is because of the textured haptic that has come out in the torics, but it's also not there in the monofocal. I don't know, something has gone in which does not produce the typical salami sign that we have a tough time separating the haptics from the optic, particularly in winters with the help of visco. It never ever happens with this, and it unfolds. There are faint stretch marks and at times 1 or 2, but they disappear within seconds, 10 seconds, and they disappear, and it stays like that. It is glistening free as a material. It has a proprietary design. All the IOLs shift in the bag after implantation, maybe minimally by a degree of maybe 0.4, 0.3 millimeters, but still they're likely to reduce a bit of lower and higher order aberrations if they shift from the optical axis. But this, even if it shifts, it has a tremendous resistance not to produce any coma. I have tested this with the help of eye trace, both pre-op and post-op. Believe me, they remain terrifically stable. I'm not saying it's a huge factor, but if an IOL induces higher order aberrations later on, the quality of vision from the patient's perspective does go down. Even if it's by an iota, it does go down. So the quality of vision is maintained after implantation as well. The median rotation is not at all there. This is also the refraction stability and the astigmatic stability post-implantation is superb. It has a textured haptic which additionally controls the rotational stability, or mimics or dictates the additional rotational stability. Now it's very interesting that when you implant the IOL, and I implant all my IOLs under BSS, I don't use viscoelastics, particularly for torics, it is very surprising to see all the IOLs rotate in the clockwise direction. It is mandated, or it is advisable to rotate them in a clockwise direction and align them along the desired implantation axis. The Vivinex toric rotates with ease clockwise. It also rotates with equal ease anti-clockwise. So even if you are off axis by 10 degrees and you don't want to rotate the IOL all the way, particularly if you think that the zonular support is not that good, you can comfortably rotate it anti-clockwise those 10 degrees and align it. It rotates anti-clockwise so beautifully that for a moment I thought how good the rotational stability would be post-operative. It was rotating so beautifully anti-clockwise. So I thought it might not be very stable inside the bag, but surprisingly my thoughts were wrong. Even if it rotates beautifully, when you implant it or are trying to align it, post-operatively the rotation does not happen this way or that way. So stability is wonderful. I think the textured surface of the haptics do play a significant role in contributing to this. So this is just a comparison, and as we can see, the Vivinex is doing pretty well here. The mean post-op rotation stands at 4.5 degrees, and if the toric IOL does not rotate more than or equal to 10 degrees, there's no significant change, particularly in the spectacle plane, and the patient can stay happy for years together. This is another outcome study which showed that the rotational stability in comparison to the other leading platforms of toric IOLs in the industry is pretty good and acceptable. This is what I was talking to you about. The coma in the post-operative period in a pseudophakic eye always comes in if there's an IOL tilt or an IOL shift. But the coma in this case, I did not believe this slide unless and until I saw it for myself. So I did a comparative observation between the pre-op coma and the post-op coma in a lot of implanted patients, and I found that it actually does not induce any coma at all. And as I said, if the higher order aberrations, if the coma is 0.3 pre-op, and even if it increases to 0.5 post-op, the patient might not reduce quantitative vision. It might still remain 6/6, but qualitatively the patient might just lose a bit of clarity and contrast in the outcome. So this is how it is achieved. The aspheric design, it is proprietary. I really have not gone into the details of what is the proprietary design and how does it resist that, but it does resist that beautifully. So this is, as we were discussing a while earlier, this is the iCert platform, wherein you had this hub which used to be screwed. So I had a little bit of an issue initially, because I implant all my IOLs under BSA, so my left hand is not free to rotate this, so my assistant always screws it in. And if you don't screw it in yourself, you would not have, I mean, there's another user dependence which comes in, but with the multi-cert platform which is available now, you can choose to push it in, and the push technology is even smoother than the screwing in technology with this particular assembly, I believe. So this is how it is. I mean, there are 3 steps, very, very easy. Put in visco, dislodge the lock, then disassemble the assembly, I mean, take out the whole cartridge thing from its holder, and then just advance the plunger so that the bifid plunger takes the trailing haptic along with it, folds it onto the optic surface. The nozzle is beautifully designed again. There's a notch which folds the advancing haptic onto the optic surface, and then it is ready to go in and occupy its place in the back. Toric calculators, well, Hoya has its own. Every manufacturing company has its own toric calculator. You can choose to use the calculator which is inbuilt in your optical biometer, or the various calculators that are available online, all of them being free. And all of them now have the Barrett's toric calculator incorporated, so it hardly makes a difference which calculator do you use. They all sing the same song essentially. However, if there is a difference, my recommendation would be, if there is a difference between different calculators so as to predict which model of toric should go in, it's always advisable to rely on the online calculator finally, because that's the most advanced one and that's the most updated one. So the algorithms keep changing, and Dr. Barrett always updates that in the online platform. So it's always better to zero in on the online calculator should there be a difference in the different calculating formulae. So this is how the IL looks like. It's not anything hugely different from what we have already seen thus far, but the only thing that changes is the textured rough haptic surface out here. And then the alignment holes. The alignment holes on the optic surface are very prominent and big. They sometimes are important, particularly if you're handling a case which is a small pupil and you're trying to align a toric IL along a small pupil. These very prominent deep holes actually help you see the holes, see the lines, and enable you to align them properly along the desired axis. So they really come in handy at certain times, not always maybe, but at certain times, say in hazy cornea or small pupils, they actually help you a lot. Not a huge difference, but still it is a difference. And then the optic surface is smooth and it's a thin and textured optic edge. These are of course the advantages that are there. The power range that is available is from +6 to +30, and the astigmatic range is from T2 to T9. So it starts from 1 on the IL plane, which corrects up to 0.5 in the spectacle plane and 0.75 on the corneal plane. T2 and T3 would have a difference of 0.5 diopters between them, and then when you go on from T3 onwards, it will be having a 0.75 difference. Now there has been a lot of talk amongst ourselves, should there be a less of a difference between the spherical range and the cylindrical range, meaning the spherical, should there be increments up to 0.25 between the spherical powers and 0.5 essentially in the cylindrical powers in torics. But it hardly makes any difference actually, because the residual astigmatism on the spectacle plane extrapolates onto somewhat like 0.15 to 0.2. That's not even amenable to get corrected with glasses, so it hardly makes a difference if it's brought down to 0.5. However, there are a lot of things that you must consider. One of those is the toricity ratio. So if you have a higher spherical power, then you need to correct the astigmatism lower on the hypermetropic side and higher on the myopic side. So the toricity ratio should always be kept in mind. Dr. Barrett has done a wonderful job again to incorporate the toricity ratio in his algorithm, in his calculator, but still it is always better to refer the chart of toricity ratio and find out how close you are to the predicted values. So that's also something that we must, so the key highlighting feature of this particular product is 1, 2, 3. If I count, then the material quality is superb. It gives you excellent refraction stability in terms of the spherical residual post-operatively over a period of time. The rotational stability is very good. It has textured haptics. The rotational stability is very good. And to rotate it inside the bag, also it is pretty smooth and easy. Prominent prominent alignment holes so that you can align them exactly along the axis wherever you want to leave them. And of course, not to mention Hoya's fantastic implantation science. The way it has been designed and developed is absolutely commendable. So I think in a nutshell, this is all about, I have implanted, I don't know, I've lost the count, I cannot tell you in numbers, but it's close to around 40 to 50 in a month from this particular manufacturer. And I cannot say that I have even a single recorded refractive surprise, so to speak, in the post-operative period thus far. Fingers crossed, it's still in the evaluation process. Of course, I cannot say that I've implanted thousands and I'm concluding that it's perhaps the best, but still, it definitely ranks as one of the best and promises to be really satisfactory, both for the practitioner and for the patient. Thank you so much, ladies and gentlemen, for your kind attention.
Thank you, Dr. Mishra, for that wonderful talk. So I think with your experience and so what has been your experience head to head? I mean, the most important concern still remains is the rotational stability. So do you feel that even for the extremes of cases, when I'm talking of extreme myopia and extreme hyperopia, maybe +6 and maybe +30, and with high cylindrical errors, so do you feel that this still remains very stable as compared to the other industry products?
So the most important thing there's nothing wrong with the hypermetropic eyes. I mean, this material is so malleable that the haptics, even if they're folded or kinked a little more, it does maintain a very good shape inside the bag. So I'm not concerned about the hypermetropic side of the axial lens. On the myopic side though, if the wide to wide diameter is close to 12.5, 12 or more, 12.5 or more rather, then I would be a little concerned and I would perhaps explain it to the patient that you might not have, and if it's particularly if it's a high cylinder, then I would explain the patient you might not have this stability over a period of time, because the equator is so, even if the overall diameter of the IOL is 13 millimeters, even then the equator is so far off that it might not be able to hold the contact angle, the contact surface, the contact area of the haptic with the equator just lessens a bit. So they might just rotate, which in a lower toric might not affect that much to the patient, because you need a 10 degrees off-axis placement or a 10 degrees rotation for a 30% toricity loss, which does not count much in lower torics, but it does count a lot in the higher torics. So I would explain the patient, you might just need to go in for a touch-up sometime later with the help of laser. But otherwise, for a large group of patients, these are very few in the subgroup, but for other patients, by and large, it behaves very well in terms of rotational stability, even if the size of the eye is variable.
I think that is one of the major concerns with all these toric IOLs, and I think with my personal experience also, Hoya is doing amazing. I mean, their rotational stability, though on the table it looks as if it might flip, but actually doesn't translate on
Absolutely.
So
Absolutely.
it remains where you have actually placed the lens. And I fully agree, whether you go clockwise or anti-clockwise, in either ways, you can easily manage the lens, and then it remains stable there. Yeah. So I think with your personal experience, we can pass on the message that it's a wonderful product. And
hands down on the table, sir. Absolutely. You just have to build your inventory as quickly as you can.
And that mindset has to be changed, where people are still resistant to use toric IOLs just for the concern that they might have surprises or the lens might rotate. So I think a clear message that the lens remains stable where it is, and the beautiful delivery system
Absolutely, these are premium products, and if you are promising a premium result to the patients, the strongest part of this message should be that if you're promising premium to the patients, you should be using something that is premium as well, because non-premiums do not deliver premium results.
So, any questions for Dr. Anurag? So, thank you, Anurag, for enlightening us.
Thank you, sir.
That was really wonderful. Thank you so very much. So very good morning and welcome you all again to this wonderful Hoya Industry Symposium. So I think in my practice of over 22 years, I haven't seen any lens making company to grow as fast as Hoya, and believe me, the only credit that we can give to this is their amazing products and the delivery system. I'm really a fan of this wonderful product. I've been using products from all different manufacturers, but what really enchants is the material and their delivery system. And not only that, it's the consistency or the repeatability that every lens behaves in the same way. So I think kudos to this wonderful industrial product. So what I'll be talking in the next 5 to 10 minutes is the wound integrity with the Nanex Multicert. And I do not have any financial disclosures. So this is just a small clip which I recorded just a day before coming. Just watch. This is a typical some another preloaded. Just see the wound. I just wanted you to see in the slow motion the wound and the way the lens behaves. So it's in the wound and I'm trying to push. There is a stretch. So just watch at the stretch and just watch the lens. So it simply goes and shoots. So watch again. Just see how much is the wound getting distended and the lens how it behaves. So it abnormal opening of these kind of lenses where when you're trying to push these lenses, they might go on the opposite side, cause dialysis, cause damage to the iris, damage to the bag. And just watch a polar cataract, carefully done phaco, and this is what you see is a very smooth, consistent delivery where you can actually slowly nudge inside the bag, and that is what most of the surgeons, we as experienced or maybe beginners, would always request and require to these lenses. And just watch, this is a beautiful overlap, 0.5 millimeters all around the lens. And believe me, the lens is going to remain stable whether it's a toric or a non-toric. And even if these multifocal or trifocal lenses which the company is planning to begin starting, so getting a good effective lens position is what is the behavior required. So importance of preloaded, why preloaded at all we require? So most of these injector cartridge delivery systems usually behave in a very erratic manner. They are unpredictable. Always there are risk of potential complications, and for me the most important, when I rush, we have done a lot of dialysis, damaged the iris, damaged the bag, damaged the endothelium, and because of their unpredictable behavior. Yes, cleaning has always been an issue, sterility is always an issue, and there is definitely an impact of cartridge on the IL surface. We have seen a lot of Indian manufacturers where once you pass on the lens, it rubs against the cartridge and you have those material sticking onto the surface of the hydrophobic implant, which you keep on rubbing with your irrigation cannula, and on day one it gives an impression on the slit lamp and might as well interfere with the vision and give you some photic phenomena. So manual loaded IL delivery system. So pre-operative, we have to sterilize those hand pieces, you have to have those cartridges, you have to pick up, you have to load, and you have to every time ask your nursing staff to wash them properly, metal injectors and the IL forceps. And what if we have good, beautiful delivery systems, which, intraoperatively, once you have done the good phacoemulsification, you just need to go in and inject this system. So gone are those days, I believe, where you actively, involve all these steps of opening, folding, picking up the forceps, loading into the cartridge, setting into the handpiece, and then implanting. I think all these steps in turn are one of these causes of losing stability in your OR. So if all of these steps are gone and you just have to directly take the product and push it, I think that's so very wonderful, saving on time, giving you that extra peace of mind, giving you that consistent delivery system, and where you have a mindset that yes, no extra organism would be there, and you don't have anything all around the IOL which might cause an abnormal TAS or an abnormal reaction on day one. So no human touch from the manufacturing to the implant is what the goal should be, and I think the whole industry is drifting towards this preloaded delivery system, giving you the ultimate stability and ultimate peace of mind. So we have seen how the cataract surgery has evolved all these years, 70s to 80s, 90s, where the incision size has really gone from almost 12 millimeters to now what we can say to almost less than 2.2 millimeters, or as close to 1.8 or 2 millimeters. So this has really transformed our surgery to decrease of the post-operative astigmatism. There is always, it reduces the risk of the lesser the incision size, the less is the incidence of the post-operative wound infections, and it transforms into early recovery of the patients after the surgeries. So definitely cutting on to the incision size translates into a good day one refractive outcome in most of these cataract patients. So this Nanex Multicert product is basically a hydrophobic, a quick word of the lens material. So it's a hydrophobic acrylic, and overall it's a 13x6, and it's an aspheric design with sharp optic edge, which contributes to the lesser PCO apart from their active oxygening on the posterior surface. It's a modified C-loop with a 5-degree angulation, and the surface is again treated with active oxygen processing, which gives you a good addition between the posterior capsule and the lens, and thereby their technology helps in preventing those early PCOs. And the power is from +6 to +30 in diopters of almost 0.5. So I think for me as a refractive surgeon, this is very important, where we have the lenses with these increments, and actually once we are working with the higher end optical biometers like ILMaster 700, and where we are doing laser assisted cataract surgeries. So actually what is more important is being bang on target with the lenses. So at the same time, I'll request the industry to supply us just the accurate power which is required, and more so with the toric IOLs, because any 0.5 plus and minus would again as Dr. Anurag was saying, induce aberrations and would give you the suboptimal results. So this is the delivery system with this, which is a disposable preloaded system, and the type of the injector, it is called 4-in-1, because you have 4 options here. You can either screw or you can push, and at the same time this is the sleeve here which can be pulled so that you can have either a wound assisted delivery or you can have in the bag IL. So this is called the insert shield, and it depends on the surgeon's choice. Now for me, this insert shield has been a great aid when I'm dealing with those non-dilating pupils, when I'm dealing where patients, I just want where the bag is a little compromised on the zonular part, and there is some amount of zonular weakness. I don't want to actually push or pull the bag, so I just want the lens to directly deliver inside the bag. So I would, in all these patients, a small pupil and compromised zonules, I would pull this shield and ensure that the lens just goes and sits inside the bag, snugly opens inside the bag. And this is, I would appreciate, this is a wonderful concept of this shield here. So the nozzle size is 1.62, which is claimed to be the smallest size in an open loop preloaded hydrophobic IOLs, and the incision size can be as close to 1.8 millimeters. So with this beautiful injector delivery system, you have a good hydrophobic acrylic lens material, which gives you that peace of mind of low or negligible PCOs, protects the integrity of the wound, and gives you a very outstanding delivery system. And what is more important is the delivery is consistent. So I think this is very important, that every lens, whether it is +6 or +30, it behaves and unfolds and reciprocates in exactly the same way. So this is very important, as against to the IOLs that we have been using. We have been seeing that IOLs where you have more than 25 diopters, those lenses which unfold in really an abnormal way, and at times you might have those haptics or the optics getting fractured. So and then again the 4-in-1 preloaded delivery system with this the multi-cert. So over 10 million lenses so far implanted with this hydrophobic material, which itself proves their the quality of the material. Now this is a quick slide for the active oxygen processing, which is claimed by Hoya, and this is on the Nanox and the Vivinex platform. So this active oxidation would enable and prevent the early PCO. So it basically translates into the additions between the posterior capsule and the optic surface. So if you see here, this is the nozzle diameter, and this is the iSert, the 250 and 251. It's 1.82, then got down to 1.78 and 1.7 with the Vivinex, and now with the Nanox it's gone down to almost 1.62. So this is the slow transformation that has occurred, and actually now we are standing here with the smallest size nozzle, claimed to be the smallest in the world. So this was a wonderful study done by the David Apple laboratory, where they were trying to with the calipers, they actually before the IOL implantation and then after the IOL implantation in the porcine eyes, they were measuring the size, the wound size, and the various knife sizes used. And if you see the bar chart here, this was the Nanox 2 millimeters, where the incision was 2, and it came out finally the incision size after the IOL implantation was close to 2.25, as against the Raven was 2.4. So more of wound stretching here. And if you see the Nanox multi-cert here, 1.8, final incision size was close to 2.18, as against to, if you see, this is the Zeiss CT Asfina, which came down to 2.37. With the Ultra Cert, it was with the size of 2.2 was stretched to almost 2.56. And with the iTech from 2.2, it was almost 2.62. So all in all, Nanox is the platform which causes minimal wound stretching, and that is what is required. Once you are hydrating the wound, you don't find the wound leaking, and you have the two lips adhering very close to each other. So consistency is also what is very important. So there are no leading or trailing haptic tucking failure. So we find all those kissing haptic optic, and you keep on waiting for them to release. So I think as Dr. Anurag pointed out, it's one of the reasons is the textured the haptic, but in these lenses still the techiness of the optic and the haptic is not there, and it actually every time that you implant the lens, it opens up beautifully and goes and sits inside the back. There are no broken injector tips after the IL release, and you don't find those haptics getting broken or cracked, because it opens up, almost uniformly in every patient to my experience. So every surgeon has its own criterias. One would use a push, the other would use a screw type. So if I am using a hydroimplantation, I can easily go with the push type, and if I want a very consistent delivery, I might go in with viscoelastic and use the screw type here. And the depth management, as I said, with the shield can be done. So you can have the shield getting pulled if you want into the bag, or if you just want a wound assisted, you can just have as it comes in. So all in all, it suits the bag of all the surgeons, and gives you a very good consistent delivery system here. So this is what is the 4-in-1 multi-cert. The push, as I said, this is the screw where you can hold with your one of the hands, and your dominant hand would be screwing the lens inside the bag. And the insertion options, you have this the nozzle which is pulled, and this is almost into the bag. And then if you don't want that, you can have a wound assisted delivery system here. So the various competition available in the world market with the preloaded platforms, I think this is Nanax is a very beautiful preloaded system with an aspheric design, active oxygen. The incision size is as close to 1.8 or maybe less, and it shows a very good moderate kind of unfolding where it's neither too fast nor too slow. And believe me, what is more important is the consistency, that every time you have the lens, it opens up in the same way it would do every time with any of these extreme of the diopters. So all in all, a great fan of this delivery system, and thanks to Hoya for giving us this wonderful product. Thank you. So thank you very much. So I would like to invite now the next speaker, and he also would be enlightening us with his experience on the delivery systems with the Hoya IOLs. So welcome.
Good morning, everyone. First of all, I would like to thank AIOS Scientific Committee, who has given me an opportunity to speak in front of you all. Today, I am going to speak on benefits of good preloaded IOL delivery system, as already discussed by Dr. Anurag and Dr. Goel. This preloaded IOL injector system by Hoya, and have this preloaded IOL injector have many desirable features if you are comparing with the manual loaded system. First, it is very easy to prepare, and it increases safety by reducing the risk of contamination and infection, and the chances of IOL damage is also very less. This preloaded system reduces the number of contacts what we are with surgical instruments during preparation, which helps to reduce the risk of bacterial contamination, and it doesn't require any reprocessing, and by this the risk of cross-contamination is less. By this preloaded IOL injector system, we are less reliant on the skill of a person who is loading the IOL, and the chances of IOL optic scratch is very because of the forceps is very less if you are using preloaded IOL injector system. The best is it minimizes the time spent which we are preparing for the IOL delivery system, and it is creating fewer instruments to reprocess, and it has been assumed that a total of 33.7 minutes can be saved per surgery if you are switching from manual lens loading process to a preloaded system. Means if some surgeon is doing 15 surgery in 3 hours, the same surgeon can do 16 surgery in 3 hours if he is using preloaded IOL injector system. as discussed with by Dr. Goyal, it's more predictable. This beauty of this Hoya preloaded IOL injector system is 100% you are predictable. There is no surprise in the lens, and the consistency is excellent. Means every time we are 100% assured that the lens will come in the same consistency, and each and every surgeon wants a smooth and controlled IOL delivery and unfolding with the haptic always in the same configuration. And this, a good preloaded system tucks and delivers haptics in the same way every time. No surprise, excellent control, everything is under your control. Not all preloaded injectors showed the same consistency and predictability at the time of delivery. And one of the study have shown that 47 of 85 ACRISAT system needed additional IOL manipulation as a result of presentation of leading haptic, and other problems which we are getting from other preloaded injectors are trailing haptic, haptic optic adhesion, and IOL plunger override. One more study have shown that 10% of the Technics iTech plunger tip this adhered to the plunger tip immediately after the IOL has exited the cartridge. And 10% of the UltraSat showed the trapped trailing haptic when we are using 2.2 mm incision, and intra-wound lens manipulation is very common in all of the other preloaded. 30% of cases with iTech, 20% with the UltraSat when we are using incision size of 2.4 mm, and 10% of the cases with UltraSat if you are using 2.2 mm incision. Several studies have found that single-use preloaded IOL injector system have been found to reduce the risk of contamination, and the need for proper sterilization and handling of equipment has already been demonstrated by several endophthalmitis outbreak due to contaminated material. And this manual loading and insertion leads to exposure of the lens to the surgical environment, and that lead to the introduction of bacteria and finally to the endophthalmitis. A fully preloaded IOL requires fewer touch points, and in case of non-preloaded IOL, touch points are more, and that may lead to contamination and lens damage. These are the two pictures in which we are showing. In the left side is non-preloaded IOL and right side is fully preloaded. So much of exposure is there in the left side in case of conventional injector application, and here exposure is very less. We are not at all touching the lens in case of VBNex multi-set Hoya IOL. These are the Hoya preloaded IOL portfolios. They are coming with the IOL brands like iSat initially. Now they have come up with the Nanex multi-set and recently VBNex multi-set. And these key features of this Hoya preloaded are rotational stability. It's very glistening free. They are having proprietary aspheric design, 4-in-1 multi-set injector already discussed, and they are having active oxygen processing treatment, and the best is the smallest nozzle preloaded hydrophobic IOL at present in the world. This innovative design of Nanex, which allows us to do the surgery in less than 2.2 mm incision without any compromise, and it minimizes the wound stage and allows us for minimal invasive surgery through the smallest nozzle size available for an open loop preloaded hydrophobic IOL system. And already I have discussed regarding the predictably lens release, which is the Hoya unique patented preloaded IOL delivery mechanism through which the predictably lens release is excellent, consistency is there, smoothness is there, and they are having 4-in-1 IOL preloaded IOL system, and it provides the choice push or screw injection. This Nanex 4-in-1 preloaded IOL system provides multiple choice at your fingertip, a single-handed push in the and two-handed screw within one device. Nobody is having this kind of device now at present. Though in the same lens we can get the single-handed push or we can screw it. This insert shield is uniquely designed by this Hoya company for the precise depth management of the injector tip insertion. The injector tip is very big. If you want to go directly, if somebody want to go directly an implant in capsular bag, we can go directly, and if somebody want from the incision wound, so just we have to advance the insert seal, the tip, the injector tip, the size will be reduced, and you can directly deliver it through the incision wound tunnel. Multi-set provides peace of mind. This peace of mind is very important because every time after doing excellent surgery, everybody, if you are using manual preloaded IUL, IUL delivery system, so every time we are worried whether the lens will come in the consistency or no, that you are not sure. The surprise is always there, but when you are using Nanex, the piece of my 100% we are sure. So after finishing the after doing cataract surgery, at the time of implantation, 100% we are sure if I am using the Nanex or any Hoya preloaded. But in other cases, we are not sure. So always the surprise is there, and this Nanex is highly consistent, predictability, and a smooth IOL delivery system. And out of 630 attempts, no leading or trailing haptic tucking failure has seen. It has 100% result, and broken injector tip already discussed by Dr. Goel. So it has not been seen in 630 attempts. I am using this Hoya preloaded for last 12 or 13 years, and they have written 630, more than 7,000 I have implanted, but I have not seen in any cases of any leading or trailing haptic tucking failure and like that. This one fits all, 4-in-1 multi-set preloaded injector. Everything's there in one injector. The key point is that after coming this injection system, there is a paradigm shift in the IOL injection system. Multi-set 4-in-1 fully preloaded injector system by Hoya provides us multiple choice at your fingertip, a single-handed push or two-handed screw injection within one device. It is your choice. These are the pictures of 2013, and I was fortunate to get an opportunity to implant for the first time 251 toric IOL, preloaded 251 toric IOL for the first time in Southeast Asia. Thank you.
So thank you, Dr. Shashi, for your wonderful experience. So any questions to the audience? What time does the session end? It's 12 o'clock? So we have 5 more minutes. Is Anurag here? Okay. So I would request, we are really thankful to Hoya for giving us this opportunity here and for holding this industry symposium for the AIOS. I would request somebody from Hoya to please come up and update your the latest products in pipeline that you have, so that we can get enlightened and be prepared for new surprises coming from you, because it's been such a nice journey. And you can please come here and yeah.
Hi, good morning, everybody. Thank you so much, Dr. Sonu Goyal, Dr. Shashi, and Dr. Anurag for such a nice presentation on the products. To update on the upcoming products, we'll be coming soon with the Vivinex Geometric, which is a brand name for trifocal range and trifocal toric. So trifocal and trifocal toric both put together will be launching soon. Maybe in a couple of months you will be having in your hand. And following with will be launching the EDOF category also, which will be the brand name by Vivinex Impress. So these two category of the technology will be launching soon, and we'll be having then the complete range of IOL as far as monofocal toric, trifocal toric, and EDOF lenses. Thank you.
Congratulations for that wonderful breaking news, I would call it. And I'm sure that you're going to hit the market in a big might become one of the giants in the industry then.
Of
So
course,
congratulations all in all, and I think the product speaks of its own. So I think it's the beautiful product and your delivery system which has really enchanted most of the surgeons all throughout the world. I think, and big kudos to you guys.
thank you so much, Dr. Sonu and Dr. Shashi. Thank you, sir.
So I think we'd like to end up this session. Any view, Dr. Shashi?
We are also waiting for the preloaded multifocal and EDOF lenses so that we can start this preloaded, because after doing the high packages and all, we don't want any surprise when we are implanting the lens. So because of that fear also, we are still not doing so many multifocals because of